just this year. But the good news is that we're back on for February. He's booked his flights, and God willing, all will go well, and we'll have Dr. Miles with us in South Africa for two-day courses in Centurion and in Cape Town. So look out for those dates. More information will be on www.scivisionmedical.com website. And just a couple of house rules before I hand over to Dr. Brian Scher from Cape Town. So just please refrain from using your raised hand, but type any comments or questions into the question and answer tabs. In terms of CPD certificates, they'll be loaded onto the SADA platform, and you'll be able to access all your certificates under your member profile name. And if you're not a SADA member, you'll be able to create a profile for yourself and access your CPD certificates there. And for those who are wondering, tonight you'll qualify for one CPD point. So that's good, but I'm sure you're going to get a lot more value than actually 1 point from Dr. Dal Mars, because he packs a punch into an hour. And then also, please, a reminder to complete the evaluation after the webinar, and we'll be telling you about the next event. There is one more SADA event upcoming, part of the Stronger Together webinar series. So well done to SADA for bringing some great speakers. And Brian Scher, you don't need too much introduction in South Africa. You're one of our champion dentists in Cape Town, and one of the first to also be on the Laser Mastership course at Aachen University. So you're quite a pioneer. You're also one of the early adopters of CPD technology, CBCT, cone beam technology that Dr. Miles will be talking about tonight. So you've got quite a bit of experience, and I'm sure you'll be able to give some valuable input into your experiences so far and how CBCT has added tremendous value to your ability to treat patients and diagnose them. So thank you, Dr. Scher, for introducing Dr. Dal Miles, and I'll hand over to you. Thank you.
Thank you very much, Peter. And we have to say a special thanks to SciVision as well for sponsoring this evening so that SADA can host it for us. And thank you very much for the sponsorship for that. And good evening, Dr. Miles. And I was looking at your CV, as we always get these CVs to look through, and I was wondering how you managed to look so young and still accomplish so much. It's looking really good. You're the chair of the Department of Oral Health Sciences at the University of Kentucky, the chair of the graduate program of Diagnostic Sciences at Indiana University. You've held positions at the University of Connecticut, University of Deloise, and Arizona School of Dentistry and Oral Health, where he was the first Associate Dean of Clinical Affairs, a diplomat to the American Board of Oral and Maxillofacial Radiology, and the American Board of Oral Medicine. Dr. Miles has been selected as a top clinician, of the top clinicians in CE for the past 16 years from Dentistry Today. And this is really impressive, authored 140 scientific articles, 6 radiology textbooks, including the best-selling one, the Atlas of Cone Beam Imaging for Dental Applications. He has a website that allows the normal dental team to be taught, and we can post that a little later, but that's quite easy, www.drconebeam.com. And while doing all that, you still hold a full-time practice in Fountain Hills, Arizona. To date, you've seen over 28,000 cone beam scans. So that's pretty impressive CV. I'm very impressed. For those who have not heard Dr. Miles before, you need to fasten your seatbelts and stand by for some learning and certainly some laughs. Dr. Miles, over to you.
Thank you very much, Brian. Boy, that sounds very impressive. You know, I wrote that all myself, so he's just reading what I send them. But I want to thank SciVision and the South African Dental Association for the opportunity to be here. This is a teaser. We're basically going to get you introduced to cone beam CT, and then if you care to come to one of the 2 courses, you'll learn a whole bunch more, trust me. And Brian, I don't do all that at once. That's over a period of, I can't even tell you how many years, okay? So thank you for the accolades. I'm going to share my screen now and go to the presentation. What I decided to do was give it a title that was kind of catchy, and I think that at least one person liked this title. Lindy Dubell kept. I think she must have read all the books or something. But anyways, here is the title: More Than 50 Shades of Gray. By the way, that's the Arizona sunrise over my garden wall. I hid all the houses down below by crouching very low. So I started this whole odyssey in 1989 into the digital world. I began lecturing on digital imaging in about 1991. And I only had one goal in mind, and that was to be on a beach in Barbados lecturing by telepresence. And here we are, video streaming. You know, it's almost done. I really had envisioned it more like this. And it didn't turn out that way, unfortunately. I can't project myself to you, but you can look at my face on the screen. So COVID kind of put the kibosh on everything, and we are now just getting back. I'm old enough to be in the first group that's going to get the vaccine early. So I'm not a first responder, but my age has shown through. So I thought I'd plug these two events and just show you, if you like what you hear today, you can see me live. I don't look any different. I'll probably look, 2 months older, but one of the courses is in Joburg at Centurion, and the other one in Cape Town. I'm looking forward to those. In those programs, I call them a mini residency because you'll learn principles and applications. So I'm going to show you a couple applications today, but just a few cases. We do a tremendous anatomy review because when you buy this technology, you have to relearn your anatomy because you're looking at over 300 or 400 slices of images in 3 different planes of anatomic section, and it can be kind of overwhelming. I do a section on reporting and documentation. I'll have a little bit more to say about that after. Risk and liability, I'm not sure in South Africa, it's important, of course, but in the US and in Canada now, the litigation, I do expert witness, and I have literally 11 cases on the go right now. None of them involve misdiagnosis. Mostly it involves me making excellent 3D images to show what some dentist or dental specialist got into that shouldn't have. I also do a hands-on portion in this course in reporting, and what we're going to do when we do the mini residency is we're going to provide you with a software called Easy Writer, and it's not just a reporting software, it's also decision support. It has pop-ups in it if you don't know what you're looking at, and you take a screenshot of the image on in your case, you'll be able to kind of compare it by clicking on a pop-up in a list of choices within the software. So we're going to give away a either 30 or 60-day trial of that. I will be bringing them to the course. So the technology or the software is called Easy Writer, and it's actually been programmed by a company called CyberMed here in Tustin, California, and Seoul, Korea. Now, I do this course, I've done it for about 11 years in a row. This past year, I did not go to Toronto, but it's a 2.5-day program where the dentists in Ontario, Canada have to satisfy this course, pass an exam in order to be eligible to buy a machine. So they have a lot of restrictions in the province of Ontario in Canada. I am a Camerican. There's my flag. I'm a Canadian and an American citizen. I became a citizen in Frankfort, Kentucky in 1999, and I can talk like this for the rest of the day if you want me to. Nobody will want me to. So I practiced dentistry outside of Toronto for 7 years, did my graduate work in San Antonio after I sold my practice, taught my first dental students in Halifax, Nova Scotia, 4 years there, 2 in Connecticut as a visiting professor, 11 at Indiana as a graduate program director, 4 in Kentucky, University of Kentucky as a chairman of half the school. And then they recruited me to, it's actually Mesa, Arizona, where the first dental school, now there's 2 in Arizona, and I was the associate dean. You heard that from Brian. So obviously, if you look at that list, I can't keep a job, correct? When I came out to Arizona, one of the things that was just becoming available was cone beam. And in the year 2001, I told the dean and basically convinced him that we had to buy a machine that was upgradable. So this is a competitor's machine to the Vatek folks. They didn't have a machine at that time, at least that they were selling in North America. So we put in a competitor, a Planmeca Pro Max, and we could get a digital panoramic. We could get extraoral bite wings, and I'm going to show you some others in a second, which means that nothing went in the mouth, and the image quality was kind of spectacular. But we could change a detector, and we could get 3D imaging just by with third-party software. Of course, this is the software I use to read my cases. But you can see that there is bone defect here on the left, in the left of the screen, the patient's right mandible. And all I have to do is click on the area, drag a circle out, click again, and I get this beautiful 3D image showing the actual bony defect. So we're moving in this technology of cone beam to visualization. I'll go back there for a second. Rather than just interpreting grayscale images, you can do things in color. And even, dentists, even in North America and whoever's using this, they don't really use color as much as they should, or 3D representation. They do it clinically, of course. You do it when you're doing your scan, your optical scan. But for cone beam, it's a learning curve, and people have to get used to the tools in their software. This is another one that we did, or another example of what we did at Arizona. We used to do Give Kids a Smile Day. It's a national campaign, and we didn't have to put anything in any child's mouth to get bite wings of this quality. So this was pretty impressive. Along come other companies and create their own extraoral bite wings. This is actually one from the PAX i3D from Vatek, and you can see the quality is outstanding. So there's been tremendous improvements as we go forward, not only in digital, but in all the software that allows you to make better clinical decisions. So the Vatek Paxera machines are very, very nice. I've played with the software as well. It's quite intuitive and quite robust. So you don't give up your panoramic. You can still do 3D imaging, cone beam imaging, and you can also do extraoral bite wings with a couple of the machines that I mentioned. All this, and you still get CBCT. So what I'm going to do very briefly is introduce some principles. I'm going to show you what's in some of these volumes. We're going to discuss one or two applications, and I'm going to answer questions at the end. That's all I've got time for today. So the program that we do when we come to South Africa will be a 2-day program, and it will pretty well fill up both days. Now, dentists are their own radiologists. We always have been. We're used to looking at grayscale images, PAs, bite wings, panoramics, and cephalometrics, but only from the side, only in the sagittal plane of section. So we'd see these, intraoral bite wings. The one on the left, of course, is I hope you can see my cursor. The one on the left is a film-based bite wing. The one on the right is a digital periapical from an endodontist friend of mine. These are exquisite images, and this is what we had to interpret. Now we get panoramics of this quality and even cephalometrics. Again, these are images that I've created from the software from Paxera. So with cone beam imaging, we've got a lot more slices. It's not just a single image you're making decisions with, but it's 300 to 500 X-ray slices. One of the major applications, and I'm not going into implant imaging, we will do some of that when we come to the larger courses, but one of the problems that dentists worry about that are doing implant imaging is dropping into a space that they shouldn't be in. Little delay there. Hope everybody heard that. Can you hear the audio? So yeah, okay. You can hear the screen audio. Did you hear the drill, Peter?
No, we didn't hear the sound of this.
Oh, okay. Hold on. I've got to do something real quick here then.
Your voice is coming through very clear, no problem.
Yeah, I've got to ask Zoom here to. There they are.
So you want us to hear the sound of your drill?
Yes, I do. I want to hear all the computer, and there's a setting in here I'm just trying to find. And now I can't find audio settings. Yeah, I'm sorry. We may not get it. I should have checked that prior to starting, but okay.
You're pretty
No
good
big
with
deal.
you're pretty good with your sound effects. Last
Yeah, I'll just make the sound of a drill, right? Oh, that's Homer. So you missed that. I'll get that right next time. So we're going from radiographic interpretation, grayscale imaging that we make kind of guesstimates of what we see, and we come up with differential diagnoses. We're actually moving, as medicine did many years prior to us, to visualization. And let me give you an example of that. I'm going to ask you a rhetorical question. When in our lifetime as dentists did we ever think we'd take an x-ray of a patient who had an impacted tooth with a cyst around it and be able to see the occlusal surface anatomy? Now remember, I'm using a third-party software because I can't own all the different machines. And this is made possible through the software I'm using called On-Demand 3D. So you're looking at an impacted lower right third molar, number 48 internationally, or number 32 over here. And you can see the resorption of the roots. You can see that it's lying with its crown facing the tongue. We're sitting on the tongue, and we're looking at the occlusal surface. If you're not impressed by that, you might as well just log out and forget about your CE, because that's an impressive image. And I have in this particular software a virtual endoscope. So I can actually get high resolution images. I can go down an airway, I can go in the ear, I can go around the head of the condyle. So there is software. We're moving towards the same thing that medicine's been doing for all of these years, and that is visualization rather than interpretation. And dentists have to learn how to do this. We will show you how. So let's take just a quick example here. If you look at the patient's upper left, maxilla in the dentition, you can see that there's a supernumerary tooth. Now you remember, and Brian, I know you maybe even taught some of this. I know Emmy Parker and Curley did, Dr. Norkia, but they would teach the buccal object rule, or the slob rule over here we used, or Clark's or tube shift rule. Well, you don't have to do that anymore. You can visualize it. You can imagine what this area looks like on a bite or on a periapical or a panoramic. This is incredible. We just visualize the pathology anatomy the way we need to. So I want everybody and to start thinking, when you get your machines and you start using these tools, these software tools within them, this is the grayscale where I just outlined in red. This is all you get on a monitor when you're looking at grayscale images. We can put pixel information, that's gray, white, or black. But if you look at the rest of the scale, that's what we can do with color. And we'll have a question about that at the end. You can assign to the pixels and/or voxels. We'll explain what a voxel is in a minute. You can assign all of these colors. And remember, there's tons of shades of pink and tons of shades of blue. So the incredible imaging that you're seeing here, these are not artist drawings. These are actual patients. Every case I show you is an actual patient. The Vatex software has a really nice airway analysis tool for obstructive sleep apnea. If any of you are getting into that to help your patients who have sleep apnea, these tools are simple, very intuitive to work with. And this is what I mean, again, by visualization. And the particular software that I'm using, this virtual endoscope allows me to do the following. I think you'll be impressed with this. I can actually make an AVI video and go down the airway, and I'm pausing it there. That's a lump in someone's throat down near the epiglottis that we can bring up on the screen chair side, say to the patient, you need to go see an otolaryngologist, ENT doc, in order to have that evaluated by a true endoscopy procedure. So, you can bring that up chairside and show the patient. There's quite a bit of difference between conventional medical CT and dental cone beam. You can see, the equipment is larger, it's much more expensive. These things they require an X-ray tech. They have 2 rooms, one for doing the image processing after the image capture. Cone beam is so much simpler and very dentally specific. Now in South Africa, I know you use conventional medical CT in different ways than we do in North America. I found some images on the internet. This is truly a CAT scan, isn't it? I think is that a female? I don't know. So cone beam, how does it work? We've got a patient that we put in the machine. There's my patient, one of my heroes in life, Einstein, Homer Simpson, and Kramer from, those are my 3 heroes in life. I'm kind of a messed up guy, but you can see the Einstein there. And what we do is we take X-rays, we beam them through the patient. They strike a detector that you see over here. And all of that information is displayed on the screen, but we can make it into 3D. And taking that image, it's kind of like a cylindrical set of data. And we just strip off what we don't need and take a look at the patient. There are 2 terms you need to know. Pixel, you probably are already used to, because I've been to South Africa many times, and there were several people that would lecture through South Africa and then into the schools, teaching you about picture elements and what you can do with your grayscale images. Now we have voxels, and the voxels are different in the medical capture and the CBCT capture. A voxel is a volume element. The pixel is the picture element. And in cone beam, these are what we call isotropic pixels, meaning it's a cube with the dimension being the same on all 3 sides. So we don't get every point in the scan. We get small cubes, and it allows us to get slice thicknesses that are very small, between 0.1 and 0.5. Whereas medicine, the smallest or thinnest slice they get is about 1 millimeter on average. Now they can, with software, get down to 0.5, but they're looking at larger body parts. So for our purposes, cone beam has much higher spatial resolution and allows us to do much sexier things from a dental point of view. We will not get gray and white matter in the brain, and that's good, because none of us know how to interpret. I do a little bit, but I'm not going to go there. So conventional medical CT is a fan-shaped beam, and they have to move the patient in the gantry a certain thickness for each slice. So to get a 200 millimeter head scan, they have to do 200 rotations and then push the gantry in a millimeter at a time. That takes a long time. It also is high dose. With cone beam, it's a single cone of X-ray, and you can see that 200 millimeters are captured with 1 rotation around the patient's head. So it's much more efficient, but they're in voxels, not every point in the scan. So CT gets every point of every tissue in the scan. They can separate gray and white matter and connect tissue from bone, and we can't as well. We see bone, airway spaces, paranasal sinuses, in much higher detail, but we don't get good soft tissue definition, especially if the soft tissues are similar. So unlike medical, cone beam is faster, it's safer, less expensive, more convenient, and dentally specific. And that's good. This is a technology just ideal for the dental procedures that we do. Couple principles that I want you to try and remember. The field of view varies, and Peter and some of the people that are showing you machines in South Africa can describe that. You can get smaller fields of view for more intricate procedures like endodontics and implant, or larger fields of view. But now the machines have pretty well graduated to having adjustable fields of view depending on your diagnostic task. They all reconstruct the image data at 1:1. That's huge. That's really important. There's no image distortion. There's no magnification. What you see is what you get. And that comes right out of conventional medical CT kind of treatment of the data. The measurement accuracy in cone beam, any machine, is really 1/10 of a millimeter. So I always tell people it's how much shake is in my mouse. You know, if I'm drawing a line to measure an implant site, it's, you know, how many single malts did I have the night before? Ah, just kidding. But it's how much shake is in the mouse. And then the voxels themselves, we can do things too. Okay, we can actually assign things. I'll tell you about those later. So the field of view, these are the typical, you know, there's a small field of view for endodontic applications, slightly larger, maybe 4x4 centimeter for implant, because you want to see the opposing dentition. There's the traditional 8x8, which is very popular size, great for doing implant, endodontics, and other things, looking at the entire dentition, the periodontium, but you don't get condyles. You might have machines that allow you to take a separate scan or stack scans to get the condyles, but if you want condyles, you have to go to a larger field of view. So the images are all one-to-one, meaning I can make a tiny image or I can make it fill the screen and the relationship doesn't change. All my measurements are extremely accurate, and they're all accurate to within 1/10 of a millimeter. Why is that important? Well, here we are with an implant image that we're looking at, and you can see that we've measured, we've got over 14 millimeters of distance between the alveolar crestal region and the nerve itself. So we're going to put in a 12 millimeter implant. In actual fact, I put in a 13 millimeter implant because I can measure that accurately. And if you use a surgical guide or stent to actually allow you to do your drilling and then placement of the implant, it just makes life so much easier. If you, in many softwares, if this looks like one that I would have placed, because my emergence profile is going to be right into that too. That's why I'm a radiologist now and not a dentist. But you can change that orientation and in many softwares to make sure that you paint the nerve, you know that it's in the right orientation. It doesn't contact the nerve in any area when you're looking 360 degrees. You can safely put an implant in there. And in this particular case, it's going to be a 4.2 by 13 millimeter implant. You can have transparent modes to show you after you've mapped the nerve, the approximate location of it. In the thin slice data, it shows you precisely where it is. I'm not a fan of these transparent images. They're cleaner, dentists like them, but I like to see full surface rendering, such as you're seeing here. So I told you, and we're almost done with the principles. The voxel attributes are important. You can put colors into the pixels or voxels. You can make them transparent and you can give them opacity. So if you look at the image on the right, you can see that there's color. The nose is blue. This guy works for the Blue Man Group out of Las Vegas. Just kidding. You can see that the bone is got a different coloration, and you can see through the soft tissue, the teeth and bone, because we've made this area transparent. So it's outstanding what you can do with these images. Let's give you an example. This is a MIP image, and both, this is in the software I use, and there is a MIP tool in the Vatek software as well. And it stands for maximum intensity projection. It doesn't look very diagnostic. If you look at this, you'll see that all we see is tooth and bone. But wait, we've got tooth number 2-3 going north. We've got tooth number 1-3 going west, and we've got a supernumerary here. We can go in thin slice and we can start to scroll, and you can see here is tooth number 1-3, tooth number 2-3 with the orientation we told you about. Where is the supernumerary? Well, it's not there because I haven't scrolled through the data volume yet to get to the location of this supernumerary tooth, because these are 1/10 of a millimeter slices, remember. But watch what color can do for you. You are not, as a dentist, going to approach this on your own. You're going to enlist an orthodontist or maxillofacial surgeon. You may want to capture this one and try and get it down into place. You may have to extract this tooth and maintain space for the cuspid area later on. But if you send a recommendation or a letter of referral to the orthodontist and the oral surgeon saying, we'd like you to be involved in this case, we want to plan this together, one image will show you everything you need to know. And you can see it here. This is a 3D surface rendering. There's the supernumerary. It's already erupted into the nasal cavity. 1-3 probably can get down into the space with some work. 2-3 is not going anywhere. There's not enough space. It's got, not only is it 180 degrees to its normal orientation, it's 180 degrees. We're looking at the palatal surface. There's no way you could make that determination from plain films without a lot of, mental exercises. So one image shows everything that you need. Quickly for dose, the dose range currently for, across the range of different machines ranges from as low as 12 microsieverts to about an average of about 120. Some are a little higher, many are lower. So this is not high dose. This is high dose. If you're doing conventional medical CT, it's 2,100 microsieverts. So these are 2 orders of magnitude less than the dose from conventional CT. No one does conventional CT to do implant anymore in North America. If we walk around the planet, our total on an annual basis is 3,600 microsieverts. Well, one conventional medical CT scan is 2/3 of that dose, whereas the cone beam volume, you can see it down here, is minuscule. So you can't even separate out, would there be any effects from cone beam, because we can't radiate the population and find out how much, 100 microsieverts might cause damage when we're already getting 3,600 from just daily living. So these are the typical doses that I lecture and quote: 5 to 10 for a digital pan, 18 to, we'll call it the 12 to 120 for a cone beam. This is from somebody else's data. 2,100 for a conventional CT, and an annual dose of 3,600. So there's a huge move afoot in North America to get child CT doses down very, very low. And I can tell you right now, cone beam is making a huge, huge impact in the ENT world. The otolaryngology people are adopting it because kids get sinus disease too, and we don't have to give them all this dose to assess the sinuses, and we can see them beautifully. All right, so just to put it in perspective, I love this. I spend a lot more time on it than I will today. If you live in New York, your risk of dying for every 2 days you live there from mugging or from air pollution is 2 days. These are from insurance tables. And the risk is equivalent to 1 in a million, which is equivalent to a full mouth series of film-based intraoral x-rays. So if you have one set of full mouth x-rays in your lifetime, it's equivalent to 2 days in New York. Is everybody leaving New York? Well, yeah, but that's because of de Blasio and Cuomo and all that, not from the muggings. If you canoe, 6 minutes in a canoe, your risk of drowning. Cycle 10 miles, risk of getting hit by a car and killed. Riding in a car. Peanut butter. Peter, don't serve me any peanut butter when I come down there. This is where I'm going to die, obviously. Drinking a half bottle of wine. I mean, we're talking at least 3 to 4 bottles a week between my wife and I, with our dinner meals and whatever, and 1.4 cigarette. So we really take all of these risks for granted. We're not giving up a lot of this stuff in our life. What's a little dose from cone beam machine? I love this, my favorite cartoon. The X-ray, the radiologist saying to the patient, we're going to have to take another one. This one's overexposed, and you can see the guy's arm is smoking there. So, all right. Now, if you talk to the people from the manufacturers, they're going to talk about ROI. As a radiologist, that's region of interest for me. That's a true radiology term. But for you guys, it's return on investment. And I'll do a real quick one here. I don't know about South Africa because I don't know your fee schedules, and I know that they're probably a lot lower than they are here in North America. However, X-ray procedures, because we need radiographic information on almost every patient, are quite high. So I do an assessment tool. I send this to docs when they're trying to decide whether they can afford cone beam or go to cone beam. They fill out this and they send me the information. One of the things that I ask them to do is run a productivity report. I took the gentleman's name off this. This was done, this was his version from January 2019 to December, so 1 year in his office, and he totaled up the procedures. Bite wings obviously are his biggest thing. He took 25,000 sets of bite wings. He did 5,500 panoramics. And with the fees that he charged, this is what he grossed. 50,000 US dollars in 1 year just from average x-ray services. Now, I don't know what he's going to charge for his cone beam images, but he's going to get better data to make better decisions. So he's going to pay for it probably in a very short period of time. This is quick. Medicine doesn't have one imaging modality that they will do everything for them. There's lots of different ways of looking at, the patient data, and that's the same with CBCT. It's just another modality. It doesn't mean that because you have one, everyone gets one. You just want to determine what the tasks are that it's going to help you with. But your return on investment will be quite quick. I'm sure the people at Vatec and other companies can help you out with that, but it will lead to better patient care, better imaging, better decision-making, better treatment. Where's the downside of that? There isn't any. So you can have this type of image quality. You can do 3D. This is actually from the Vatec software that I have a copy of and I play with periodically. This is a very nice surface rendering. They had elongated stylohide ligament complexes back in here. So you can do all that. I don't think that you should actually do much with the reconstructed panoramics from cone beam. They're never as good. This is a typical example, and I didn't do anything with this, just reconstructed. But patients vary. No patients are identical in size or body mass. The reconstructed image enhances scatter from some of the restorations that you have in some dentitions. Soft tissue scatter is a real problem. And despite the low dose, if you take a cone beam just to get a panoramic image for children assessing their mixed dentition, that's not justified. So this woman needed to, eat a lot more hamburgers, and this guy ate way too many hamburgers. And so they're not going to look the same in the cone beam machine if you don't change some of the factors. And the people in the industry will teach you how to do that. So the message: do not give up your conventional panoramic. Look at machines that will allow you to do conventional pan as well as cone beam when you need it. Anatomy, we don't have, I do 3 hours of anatomy in the program, the mini residency, but I want to show you something. Everybody will recognize a condyle, hopefully, and this is an axial plane of section. There's your ear canal. There's some schmutz in the maxillary sinus, some junk. Here's the condyle. I guarantee you no one could tell me what this is, even Brian. I'm going to ask him afterwards, but that I just outlined, oh, there we go. That's actually the canal for the carotid artery. It comes up here about 1 centimeter from the condylar head and runs along the floor and upward to come to rest near the sphenoid sinus. If you don't know your anatomy, that's number one reason to sign up for the program. But I have a very inexpensive app on from the App Store from Apple called Scanatomy. Okay, it's $9.99 US, and it takes you through anatomy in 3 planes of section, multiple examples at different levels. There's my backyard, Peter, so you got to come and visit me. Renzo, whoever wants to come. That's what I look at, 6 months of the year, because we get a lot of dust in the air and it makes for good images. But some people buy a small machine because they think it reduces their diagnostic responsibility. Well, okay, if you got an 8x8 and you're just looking at dentition, fine. But what if you had to look at a third molar area? Well, you move it back and now you've captured airway. So you got to know something about the airway, something about the spinal column. Let's say you move it up to capture the condyle. Well, there's the condyle, okay? And look what you got. You got the mastoid air cell process. If you move through the head, you're going to get to the sphenoid sinus, the sella turcica, so you will look at condyles, but there's a lot more data in there. So the reason I put that in is to entice you or encourage you that you need to look at what tasks you're going to do. What's the perfect volume size for you or set of sizes, because even though these are a small field of view, there's going to be stuff in it that you see that you need to recognize so that you don't, mistreat the patient. This is a coronal plane of section through molars, and you can see a little bit of inflammatory change in the right maxillary sinus. This is the patient's right side. This is the left. We're looking at them. F means foot end, so the foot end's here. End of story, nothing to worry about. Next patient comes in, they've got a small mucus retention cyst in the right maxillary sinus. Little inflammatory change, again, nothing to worry about. But if you have a small field of view and the right sinus looks like this, maxillary sinus, and the left looks like this, and there's enlargement of the turbinate or the mucosa around the turbinate, they have a rhinosinusitis. They need to see an ENT doc. And oh, by the way, if your machine allows you to position the patient and capture the rest of the paranasal sinuses, that would be good, because they all communicate. These communicate with the ethmoid air cell complex, the sphenoid sinus, frontal sinuses. And if you got this much schmutz in one paranasal sinus space, the chances of it being elsewhere are very high. Cone beam images are great. They don't come with arrows. Just want you to know that right off the bat, guys. Okay, we put the arrows on when we do reporting, but this is up to you to recognize. Now, you don't have to take additional images. You could just say, Mrs. Jones, Mrs. Smith, you've got to see an ENT doc, and they've got to do, the referral would be, patient is being referred to an otolaryngologist for clinical and endoscopic evaluation of the paranasal sinuses, because you've got to see the rest. If you've got dental problems down here and sinuses that look like this, if you treat the dental, this may not go away. Or indeed, sometimes the dental causes the changes in that sinus. Those are all things we will go over in the program. If you have thin slice, small field of view, I'll just orient you here. This is the sphenoid sinus. This is called clivus. Don't worry about that. It just means slope. This is the anterior arch of vertebral body C1 or atlas. This is vertebral body C2. Well, this doesn't look very big, okay? And the atlas is a big vertebral body. How big is it? Well, here's an edentulous patient we were imaging, and there's the atlas. What all we saw in the thin slice, grayscale view was the anterior arch, and a loose body, by the way. But if you look here, this is the anterior arch of C1 is right here. This is atlas, this is axis with the dens. There's the maxilla. So there's a lot of anatomy that you need to know, and you need to start thinking in 3D. I can't stress that enough. If someone sells you a machine, they got to spend time going over the tools with you. There is some help. I do have a textbook. It has, I'm only going to show you 2 applications, but look at all the applications. There's some anatomy and basic principles, but 1, 2, 3, 4, 5, 6, 7, 8. There's a lot of applications. I go over most of these in the larger program. But let's take endodontics. This is a primary sort of application for cone beam. You can see very high detail. You can see your MB2 right here. I didn't even know what an MB2 was till my endodontic friends started teaching me about it. I probably missed a lot when I was doing my general dentistry. But how simple is it to find just in this axial plane of section? I defy you to tell me where all of these, RCT film materials end in this periapical image. There's lots of problems with endodontic imaging, and if you're still doing chemical processing, you're really behind the 8 ball, because half the time you're interpreting images that aren't even diagnostic. So what can cone beam do? Well, here's a lesion. Do you really think that if you put even a digital receptor in that you're going to see that lesion when the x-rays have to come through soft tissue, bone, lesion, bone, soft tissue, and then hit the detector? This is not easy to do. Cone beam makes it easy, okay? So example, and again, they don't come with arrows. So this is an axial slice through the maxilla. These are the pterygoid plates. There is a lesion, I think, around this palatal root, but the sinuses dip down in that area. So we look in a different plane of section. Yep, there it is on the sagittal view. 14 is tooth 2-6. And we look from the coronal point of view, and you can see it's certainly on the palatal root. So that's very easy, and you can have multiple views. This is a reconstructed thin slice pan, which confirms all of the locations of those lesions. Here's an axial view, crud in the sinus, periapical, possible residual periapical lesion, palatal root, distal buccal root. You know, one thing I can tell you, I don't think the sound will do it, so I'll have to do my impression of Arnold Schwarzenegger. It's not a tumor. Okay. All right. And if you look here, look at this, MB2 on the second molar, MB2 on the first molar. How do I know that? Because they're already filled over here. Okay. The first molar, second molar all have 4 canals. And by the way, look at this bicuspid. 2 canals, small ones in the buccal root, 1 in the palatal. So cone beam makes your life a whole lot easier. Multiple roots. This was a case I was imaging and I saw some widened periodontal ligament space and I went, I better look at that. There was gross decay, not much periodontal disease, little overhang, but cone beam allows you don't have to take a second periapical. You just scroll through the slices and change your point of view. Well, this is it from the axial point of view, and you can see that the second molar, tooth 47, has 4 canals. Not only does it have 4 canals, it's got at least 3 roots, and this one divides. You know, this distal root has 2 sort of apices, and so this is not an easy canal structure to negotiate for you. Dilacerated roots, this is a fun case. This one was provided to me and I wrote back to when I did the report, I said, can I get the periapicals that you did on this case? So this is the digital, this is the film-based pan. Here's another, or periapical, here's a film-based one. The lesion was persistent, the patient had pain, and you can see the tremendous curvature on that root. Well, you could also see it in the cone beam. Here's where they filled the canal tube, but they missed the last probably 4 millimeters of it. And that's because it looks like this. This is this, okay? We're looking from the buccal aspect here. We're looking from the underneath. We're looking, sitting on the tongue, looking upward. So those are pretty hard to negotiate. In this transparent image, you can see that there was a tremendous, I guess it was 3 millimeters that they missed. And that was probably the persistence of pulpal tissue that caused the patient to have postoperative pain. Resorption, this is easy. You know, when I first started talking or doing digital, I'd get docs that would look at the digital images like this one on the right and say, well, that digital image doesn't look like film. Well, no kidding, Sherlock. It's not supposed to. And I used to tease them and say, I can make any digital image look like film. I'll take it into Photoshop and blur it twice. I'm waiting for the laughter. I can't hear the laughter at the other end. Ha, ha, ha. Okay.
I'll give
but
you
you can
laugh.
see everybody now prefers this. This is just with a 1x filter on the tooth. And you can see that if you were trying to determine whether this resorption was internal or external, well, you just take and look in a different plane of section. And there's the internal resorption. But in order to treat this, you'd have to get down to here, cut off the root, fill it back in, and now you've got no crown root ratio to even restore. So this is an implant case. There's no way around it. Even though you've got lots of root structure in bone, you're not going to do a root canal and then apico and whatever. You're going to use all of this big hunk of bone up here. Sorry, you're going to make your measurements and put in a great implant. And you can do it well with cone beam. This one's a fun one. There's nothing going on in this reconstructed pan except, this tooth has had endodontics, but there seems to be a little loosened area here. We go in and we go, oh yeah, maybe there's a lateral canal, okay? Well, we go in and look in different planes of section, reconstructed pan, axial, and coronal, and that's a long-standing lesion because there's a thickened area of bone around it, which means it's been there a long time. But watch what happens when we do 3D imaging. And I stripped away some of the bone to show you. There was tremendous resorption going on, okay, all around the distal portion of that tooth. And it was starting, the lesion here was starting to eat away at the tooth structure. So, and they don't come with arrows, all right. My little town of Fountain Hills, a saguaro cactus saying hi. They got one arm up. It takes 50 years to grow that arm. Okay, for the first one to sprout. Impactions, and I'll finish it up right at looking at my watch here. Oh yeah, I've got good time here. So this is an impacted cuspin. You can imagine trying to do your buccal object rule on this one, or taking a couple of images intraoral and saying, did the tube shift? Was it same on lingual, opposite on buccal if you use the slob rule? But, you know, looking at that, that's not going to be easy treatment, is it? Well, here's what it looks like in the axial plane of view. So it is impacted on the palatal side. We couldn't even tell that from the pan. Palatal side impaction, all the way erupted up to the central incisors. There's where it's trying to come through on the palate itself. And then this is the orientation when we do a typical visualization kind of procedure to it. So for impactions, it's pretty easy. More impactions, and you can see this is a cuspid that never got down into place. Okay, it doesn't really have much of a cuspid appearance to it, but let's see what it looks like. Well, there it is. It's tooth number 1-3 trying to erupt towards the buccal. You can see the coronal aspect here, kind of malformed crown. And you can see that from the coronal point of view here, you can see the crown again, and then you can see this little structure. Well, this is part of the root of that bicuspid. So this is tooth, 1-3. This is tooth 1-4, and this thing is a long way away from where it should be. So there it is. There's the root, and it's dilacerated on tooth 1-4, which you wouldn't have appreciated. Luckily, there's no endodontics being done. Here's I got two more cases real quick. This is an impacted, and I think this was a supernumerary, okay, and it was impacted, oriented towards the lingual. No, it's just 2-3-5. There is some resorption of the primary molar that shows up very nicely in these thin slice images. You can see coronally the orientation. If you were trying to get to that tooth, you might want to come from the lingual rather than the buccal, who knows. But you can see the orientation here. And more importantly, I wanted to see what its relationship was to the inferior alveolar nerve canal. And it was pretty darn close. That's the root developing and still forming, going out, and resorbing or remodeling the buccal bone. And there's the mental foramen right beside it. So this is one you're going to have to be extremely careful with. Just a different kind of configuration so that we could show how close it got to the mental foramen and the resorption of the tooth itself. Last one here for impactions, you can see tooth 14, which is 2-6. Okay, it's impacted. It hasn't erupted. Why? Well, you don't really appreciate the dilacerated roots even in these thin sections, but when you do a 3D color reconstruction, strip away some of the bone, you can see what those roots actually look like on the buccal. There's no way that's going to erupt into the occlusion. Typical way we use this is to colorize the nerve, showing the orientation to third molars. And you can see that this one is in contact with the third molar apices. I do this about 8 times a week, okay, for my oral surgery clients. All right. I just wanted to show you 2 images. If anybody is doing temporomandibular joint assessment, you're dealing with patients with oral facial pain. Do you want to make all your estimate, sort of interpretations on just grayscale 2D images in different planes, or do you want to get a sexy condyle that looks like this? I mean, that it just show you exactly what's happening to that condyle. It's got surface flattening, and here's the other one. Not only has it got lipping, that's a sign of early osteoarthritic change. It's got an erosion in the opposing glenoid fossa. So this is the type of imaging that you can get with cone beam, and I showed you several applications. So I know you need some help. I know this was just, as Peter liked to call it, a teaser. There are some resources. Here is my website, Dr. Cone Beam. You probably think I'm like Obama, that I'm very what's the term I want to use that's polite, arrogant and self-centered, I guess. But if you, sorry guys, but if you look at drconebeam.com, you think, wow, you think a lot of yourself, Dr. Miles, but this is what the industry came to call me. I named the website because I had 2 reps for different companies say, well, we all call you Dr. Conebeam. And I went, that's great. I'm going to use that one. Okay. So All right, so we've got some articles on that site. I've got links to the textbook on that site. There's also links to, this is it's not out of print. You can get single issues, and some of them I think you can get for free if you download. But we did a dental clinics in 2014, a little older now, but great stuff, all clinically oriented. And I had 2 chapters in there myself, one on systemic changes. I want to tell you that I've only just recently formed a little relationship. I don't get any compensation from Vautech, but they ask me to do webinars periodically, and then I charge them, but I don't sell for them or do anything. But I love this company in America. I don't know how Peter's doing it, but what they do is they've got a site that you can log into. It's free. You just register, and you can go, and they've got probably 15 or 20 webinars, and they asked me to do 3 or 4 over the last year because they wanted to educate their clients. So there are some sort of resources out there that you can find, and maybe even Peter can direct you to them. I'm hoping he puts this lecture up on the on the SciVision website. The last slide I want to show you is actually, I'm very proud of this. A friend of mine who teaches still at UNLV, Bob Danforth, and myself. He's a pathologist. I'm a radiologist. We made a software template for programming from Cybermed, and this is the decision support software, and I'll be able to show you that if you come to the courses in South Africa. It helps dentists not miss anything important that they must refer, and it really comes out as an elegant little report. And I will be giving away USB sticks with it on there for you we do a lab with it. So I want to thank you. I think I finished on time, maybe even 30 seconds early. We're going to open it up for questions, I'm sure. Thanks so much.
Just before Brian mentioned some of the questions, I see there's quite a few questions. I just want to say thank you, Dr. Miles. I know it's not easy speaking to a computer screen and you can't really see the faces and get a response. But that's really excellent. Thank you so much. And I think this is such exciting technology. I mean, I've been in this industry for, believe it or not, almost 30 years and being involved in so much of the technology, and from lasers to from, of course, CBCT is just you're able to diagnose and see and treat in a different way. And I think the big separator from what we're seeing from different dentists is education, because some listen to the same message and some adopt it and some really grow and learn. And for whatever reason, some others don't. We know finances is a challenge. And South Africa, we pay in dollars and euros and so on. So there's an exchange rate and such things. But yeah, I think as doctors adopt this technology, they see how it changes the way they're able to communicate with their patients, especially as well. And I think Brian will be able to add to that, And just before I forget I was supposed to say it in the announcement, because you're going to mention a number just now, and we're going to have a draw of one of the delegates of that number, and they will be able to get your course in February at half price. I think the normal price is about 16,000 or something. For those of you who don't know, that same course Dr. Miles gives in America and in Canada, I think you'll pay in the vicinity of about 40,000 Rand if you had to convert it to Rands. So we've really brought it as low as we can for South Africa. And then there's even a better price for those who are our users of Vautech CBCT technology, and even our water laser users and BioLase and so on. So last night there were some lucky draws. I just need to mention them, which I think was part of my job I was supposed to do when we started. So I'll do it now. I'm sure the winners would like to know. So winners of last night's lucky draw is Dr. Vilmarie Kruger, J. Johnson & Johnson Hamper, and then also Dr. Mohammed Basa, a 5,000 Rand gift pack from Dentsply Sirona, and also Dr. Gerard van der Westhuizen, 5,000 gift pack also from Dentsply Sirona. And tomorrow evening, as far as I know, is the last event from SADA, and it is Dr. Ricardo Mantrini, how to create a new vision for your dental practice team, which is certainly a good way to end off this year, I think, and have a vision for next year. So thank you very much, Dale. I'll hand over to Dr. Brian Scher, and you can just discuss some of the questions.
Thank you very much, Peter, and thank you, Dr. Miles. Interestingly enough, I had a mountain bike injury, and I hurt my wrist about 2 weeks ago. again, and it's kind of a long ongoing thing. So I decided to go to a doctor to have a look at this, and he sent me for a whole bunch of x-rays, and really just saw a couple of osteophytes and nothing much. And so I thought I'd go and put my hand in my CBCT machine, which I did, and we transferred the image to him, and he couldn't believe the quality of the image. And he said it's much better than he normally gets, and he could straight away see what was wrong. So that was quite an interesting little thing. It's like my diode, my lasers. I use it for everything else but teeth, almost. The same as the CBCT. I used it for everything. I've done elbows, I've done wrists. It's amazing what you can do with it. And you mentioned a couple of things. In the last 2-3 weeks, I've had a couple of sinus inclusions that I've had to refer to ENTs. I've also had a couple of canines as well, as you were mentioning, that I had to refer for the orthodontist, and where the CBCT was invaluable. I think it's a must-have for dental practice. Okay, so we've got a couple of questions for you. Anonymous, how many CBCT scans are safe to do on a patient in 1 year or during a lifetime? Does the radiation beam cause permanent damage to the organelles of the cell? And is this damage reversible within the cell?
Well, that's a whole lecture in itself, guys. With a first of all, let's go to the cellular thing. The damage to cells from an X-ray photon has to be to a DNA molecule. It has to break a bond. The chances of it doing that are infinitesimal. Most of the damage from X-ray procedures that we do in medicine and dentistry is actually from the ionization of water and indirect effects. So the chances of causing damage from cone beam or any dental X-ray procedure are extremely low. Okay, as to how many you could have in a year or a lifetime, you'd have to sit there with a calculator and say, okay, if I wanted to get to 3,600 microsieverts, I'd have to have 100 cone beam exams at 10, or 100 microsieverts. There's no way you're ever going to get close, to finding out or understanding if there is damage. There's damage from every X-ray procedure, but what people forget, okay, what everyone forgets, and especially dentists, okay, sorry, but many of you didn't pay attention in school when you got trained, is that there are repair enzymes. The damage is almost immediately repaired from that ionization of water. The free radicals don't stay around. They're too unstable, so they recombine into different things, okay? If the combination occurs on the end of a molecule that might have a problem, that's going to, be short lasting. If there was DNA damage, basically that would be carried on genetically for as many cell divisions as that particular cell line would have. So we get far more dangerous things done to us than dental X-ray procedures, including cone beam, on a daily basis. Just walking around the planet, the radon in the rocks. There's no rocks in South Africa, right, Brian?
One or two.
Yeah, well, the dose from radon in the rocks is like, 55% of our annual dose, and we can't go and dig up all the rocks or live in a boat on the ocean. So, well, some people can, but I'm not going to live on a boat in the ocean.
Okay, thank you. I think you've almost answered this already. Is there legal responsibility to the patient to point out and diagnose pathology in adjacent structures to the normal dentinal structures?
No, there's a professional responsibility there. If you had a panoramic and you were only looking at a third molar impacted on one side and there was a big multilocular lesion on the other, you have an obligation to let the patient know. So yes, you are responsible for everything in the scan. You don't have to diagnose everything, but if something looks abnormal, you need to take a screenshot, you need to get a referral. It's the standard of care around the world. If you don't know what you're looking at, you send it on to the next level of education or specialist with education that might. And it could be an oral surgeon, it could be an ENT doc, but there's an absolute obligation to look at all the data, inform the patient, you know, tell them that you don't know what the treatment will be, but you're going to send them to the next level. So yeah, unfortunately, you're responsible for everything in the scan. Now, I'll tell you in the US and Canada how it's not getting around it. It's what some people elect to do. I've got clients that take so many cone beam scans, and it takes no time to capture the image. It takes 30 to 40 minutes, you know, to not only go through the image data, but compile the images, put them in a report, and send them back to my client. For which I get 75 bucks. Okay, they get $300 to $400 for the capture, and I get 75 bucks for the report. But some people take so many scans, they say, I don't have time to go through them, so I'm going to send the reports out to a radiologist or the scan data, and then they get the report back. And that's an elective thing for that person. Others, you know, I do implants. I only do imaging 1 week, and 2 weeks later I do the surgery. I'm going to look at all the scans because I train myself to a comfort level. This is the dentist talking, and I like looking at them, you know, and I'm finding things and referring. So it's a total personal preference, I guess it is, and how productive that you can be. You guys don't make money doing interpretations of scans. You make it chairside doing dental procedures.
We have a question from Shanae. Thank you for your excellent presentation. You showed beautiful slices of MB2 canals as visualized on CBCT axial slices. In your opinion, is CBC justified to be used as a screening tool for additional canals in endodontic treatment?
That's a tough question to answer. And again, what you have to do is you have to determine what your office protocol is. Obviously, you're not going to take any image or do any imaging on a patient that doesn't come with a set of, you know, signs and symptoms, a history of pain or whatever. So if you determine that this could be an endodontic problem, take the scan. Even the endodontic community here is coming around to, you know, they see the referrals from we general dentists. So a lot of those are, oh my God, I don't want to tackle that, or oh my God, I messed it up and now I got to have somebody unmess it up. So they refer out, and most endodontists now are doing cone beam CT in North America because they just get better data. The morbidity goes down, the success rate goes up, the patient is happier. So there is no downside to it. And to go back to the dose, there's really no dose when you consider what we are exposed to on an annual basis just from living.
Can you, from Lawrence, can you use CBCT image as Ceph image for ortho analysis?
Yes, you can, but there is a big debate in the U.S., and I think what most, and I'll talk to institutional orthodontics, what most of the institutions did was say, we've got traditional analyses for 2D cephalometric images that are standardized, that have been used for years, like, you know, just 40 or 50 different more analyses, and they work well. On children under 18, I would say probably stick with traditional. On adult or, you know, young adult or older, if you're going to do orthodontics, probably cone beam would be a good idea. And especially in adult orthodontics, there are a lot of people that are getting braces at, you know, 40, 50 plus now. You know, their kids are gone, they got more disposable income. But a lot of those patients have osteoarthritic changes in their condyles. You see them in their hands, and then you say, do you have any problem? Oh yeah, you know, in my neck and my knee. Well, I think you should rule out any type of potential osteoarthritic problem that could rear its ugly head when you start putting bands and elastics and brackets and start moving teeth around, because sure shooting, you do something to the occlusion, you might stir up the arthritis. And that's okay. You can tell the patient that and say, we're going to treat this with non-steroidals, moist, all the conservative measures. But don't worry, this might happen, you know, when we do orthodontics. Same thing with implant imaging. Now, this is my opinion, and I've said this for years. I think everybody that's having an implant, if you examine the patient and you see any signs at all, Heberden's nodes in the, you know, distal terminal phalanges, or the complain about their knee or their neck or some arthritic condition, If you're doing an implant, I think you should look at the condyles. The temporomandibular joint condyle can be really ugly and not painful, but as soon as you change and put them back in function and they start chewing, they go, I can chew great, doc, here, but how'd you make my joint hurt over here? You're the bad guy. Okay. So my feeling is that in a patient with signs, symptoms, or history of OA, you probably should take a cone beam in an implant case on that adult patient, because you could stir it up and then you're the bad guy. If you tell them this might happen and then here's how we're going to treat it, they're a lot less litigious or less apt to be mad at you. Okay.
From Anonymous, thank you very much for the interesting lecture. Have you seen the extra set of salivary glands in the nasopharyngeal area on CBCT scans?
I have not. I've seen lots of enlarged adenoids and other tissues and things that impede the airway or that cause a space problem with the airway, but I haven't seen any accessory salivary glands on the cone beam. But remember, I get a lot of my 28,000 scan reports are from smaller fields of view. They're also, there's so many other things that occur more commonly. I probably don't even know if I was looking for it,
Another question, what year is the latest edition of your textbook? And is this book available in South Africa?
I should let Peter. No, I'm just kidding. We're talking to Quintessence America, because right now we've come to the end of the second edition, and it was 2012, I think, 2012. So we should have had a third edition out by now. But they still have an inventory, and they've reduced the price tremendously. In the U.S., it used to sell for 142, and now it's like 70% less than that, because they're trying to sell off the inventory before they even consider a new version. So that is the last version. It's 2012. It's a wonderful textbook. And I can say that because I wrote it, but I've got lots of changes planned for the third, but I don't know when that'll happen. And yes, it would be available in South Africa, but if you got it from Quint Publishing in Germany, it's going to be more expensive than what they're offering in the US. So we'll figure that. If anybody wants to come to the course, we're going to be thinking about getting books for that, but we haven't made the final decision yet.
Okay, another question, maybe not directed to you directly. Are there annual licensing fees involved that are due to the manufacturers of the CBCT machine, or the radiation authorities and the software companies? I know that you do have to register your machine. Every machine has to be registered in South Africa, and CBCT has to be checked every year. Yep. While your other radiology equipment, I think, is every 3 years for the most people. But I know that a cone beam is every year.
Great, yeah.
And as far as I know, there's no licensing software, not with mine anyway.
No, I mean, unless it's a totally new version, like somebody's got a machine it's a good couple of years old. It's normally like if there's version 2.1, you might get 2.133, or but if it comes to 2.2, and there's a considerable new software version, that's a different story, then there would be some sort of a fee involved usually, yes, but not just if it's a slight, part of the same sort of similar version, if you can put it that way. But the technical guys can answer that more if there's questions. But yes, you correctly answered the radiation inspection fee. That's correct, CBCT every year. And I'm speaking of correction, I think it's about, including VAT, about 5,800 for a CBCT. And then there's a different fee of about 2,000 Rand for a sensor, intraoral sensor. And then there's a slightly different fee for a wall mount X-ray. And then a panoramic encephalometric 2D is also a slightly higher fee. And that would be every 3 years for the 2Ds, but every year for a 3D.
Okay, and another question, which I think we've delved into a little bit, is can one transport images to colleagues electronically? And does the recipient need to have the same software?
That's a great question. And yes, you can transfer. You can't do it by email attachment. You have to set up. I have a server in my home. I have what's called an FTP program. It's freely available, a file transfer protocol that allows you to send large amounts of data. So my clients basically capture, scan, export it as, quote, DICOM, it's called throughout the world now. All the extensions on the slices are .dcm, okay? And if it's exported DICOM data, usually there's several, sort of versions that you can export. A lot of them are proprietary to the machine. So no, I couldn't open that because I don't have that software. But I read DICOM data off every machine. I mean, there's only about 4 that I don't have clients that own, but it has to be DICOM. So here's the thing. If you buy a machine from Peter, okay, or Vatek, you need to have them teach you, if you're going to send it out for a read or share it with another colleague who has a different machine but has software that can allow DICOM to be taken into it, you need to ask that vendor to show you not just how to burn a CD, but to export, even if it's burned onto a CD, the actual raw DICOM data. But that's what the DICOM standard was developed for, so that medicine and dentistry could share image data between. Now, I'm going to take like 2 more seconds to explain that. DICOM images are basically TIFF images, tagged image file format, or TIF, TIFF images. What does that mean? That means I can send the slice, but with the slice comes patient's name, their age, the sex, the machine it was taken on, the body part. Those are the tags. So you guys all send JPEGs around, export a JPEG, and it's, pretty good quality, but not for doing X-ray stuff with that I do, or that another person would want to do, put it into their program. DICOM, okay, DICOM, Digital Imaging and Communication in Medicine, just another standard.
Yes, I managed to, with my software, you can send the whole software with a viewer, and I use a program WeTransfer, and you just log on to the website WeTransfer, and you just drag and drop and email it. It takes about 5-10 minutes to send the thing.
But I'm going to interject there, Brian. You send it with a viewer, and that's great. But viewer software has limited capability. Usually, machine, a lot of them are just axial slices, and you can do measurement and other things. So I guess my point of view is different from your point of view, because I got to do sexier things with my images. So but okay. Okay.
So we have Janine or Jean. The best presentation I've ever attended in a long time. Thank you very much.
My head's exploding.
Yeah. What is your experience with 3D printed cranial reconstructive implants from images of conventional CT versus CBCT, accuracy-wise, and image quality?
That's a great question, but it's loaded with all kinds of other things. First of all, I don't have any experience with 3D printing. I have connections to lots of labs and lots of software vendors that capture scans and do things. The accuracy for cone beam, depending on the printer, okay, and the type of printing that's done, is very good in cone beam. I'm not sure that because we have such high resolution and can get such thinner slices when let's say they're doing a build up with the materials that they build it up with, you're dealing with 1/10 of a millimeter slices, not guessing at what lay between a 1/2 to a centimeter slice for like medicine. So 3D printing is huge everywhere around the world, both in medicine and dentistry, and we get very good 3D printed models of just about anything with cone beam data. That's about as much as I know. Now you're beyond my pay grade. Okay.
And I think that's about questions. Most of the questions. There are a couple of people who have sent you personal questions or personal comments, which we will forward to you.
Okay.
But I think to round off the questions, I'm going to quote one of the question guys, Dr. Jeff Eitzman, and he says, "Wow, impressive to have an international speaker of such high quality as Dr. Dale Miles." And he says, "Thank you very much and well done to SADA." So
you're welcome. You're welcome. My pleasure.
And to you, Peter.
Peter paid him, I'm sure.
No, he didn't say thanks to SciVision as well, which I will
Ah,
have.
there you Oh, you're muted, Peter.
Peter, you're on mute still.
Thank you. Okay. The good news is that all goes well. Brian, you'll be here too in South Africa. We're going to be using your surgery probably for demonstrations too. And Dale will be in South Africa I'll repeat the dates for those who didn't maybe get it in the beginning, 12th and the 13th of February in Centurion at our SciVision Training Center, 2 days. I think, Dale, if I'm correct, it's actually a 2.5-day course you've actually compressing into 2 days. So we're limiting the attendance to only 20 people, and you've got to come with your laptops that can take the specs because you'll be working with the software. We've obviously got technology in the training center as well that you'll be taking images as well if you want to, various different types of Vartec technology as well, plus the new one called the Green X just about to be launched, phenomenal, especially on endodontic software. And then in Cape Town on the 19th and the 20th of February, also only 20 delegates. However, as far as I know, it's almost 70-80% full. So we may have to keep you here for longer, Dale, and either extend your trip or have a midweek 2 days, because I do suspect that more and more people are going to be wanting to come and listen to you in person live. And that's when Dale is really puts up a great performance, because when you're live and not speaking to a computer screen, of course, it's a whole different scenario. But yes, Dale, thank you. I think it is wonderful to have known you for many years. I think we've known each other for probably, I think it's approaching 2 decades, if I'm not mistaken, you know. And
Yes.
I think
Old man.
Yeah. So it's been a privilege always, you know, interacting with you and meeting with you, not only in South Africa, but all over the world, in Germany and in various countries, and coming to your home in Phoenix, Arizona, even though it was hot as hell, you know. But it's really an honor to be a good friend with somebody of your caliber, and I think some of the testimonies have come through this evening. So that's really wonderful to have you. And I know you've done many trips in South Africa, and you mentioned some of the past professors and so on that you worked with, Curly Nokia and people like that. And so I know you're pretty well known in South Africa with even the older generation, you know. Maybe the younger generation hasn't met you yet in person, because I think the last time you were here was about 10 years ago, you know?
They better hurry.
So yeah, it's really exciting technology. I think dentists, it's a wonderful profession. It's so exciting. You know, I think it was Steve Jobs who said, you know, the combination of technology, IT and medical dental technology. He didn't mention the word dental, but we'll mention the word dental. But medical technology coming together is so exciting. So to be a dentist in this arena, I think is really exciting from my point of view. And you know, we're involved in many fields of dentistry, and CBCT is one of them. And to have people like you that we can use as trainers is a wonderful privilege. So Lindy's going to play a quick video for about 30 seconds. Dale, I know you've got a question that you're going to ask the audience. So after the video, you're going to ask your question. And then the quickest one that's going to answer in the Q&A section is the one that will qualify to get 50% reduction off your 2-day CBCT course in South Africa in February. So get your thinking caps on, and we're going to watch a 30-second video. Dale, you'll come back on with your question, and the quickest one to give the correct answer in the Q&A will be awarded with that 50% reduction of your course. Okay.
It's like Jeopardy.
Sarah, 5 more minutes before we go to the dentist.
But it's the dentist. The needles, the drilling, the pain.
And what about the drama? There's always so much drama. It's okay. We have a water laser appointment. There's no needles, no pain, no drilling, just some water and a laser.
Yeah, it's easy.
What's their information?
Visit waterlaze.com to find a Waterlaze dentist near you.
Okay, you can see we do a bit of cross-pollination here. So we're talking about a wavelength, and those that don't know, you get X-ray wavelength and laser wavelength. So we're into the wavelength dentistry. So, right, Dale, are you ready with your question? And the dentists that are hopefully ready with their answers, they're going to type it in, and then whoever's got the correct answer will get the prize. Over to you.
All right. I don't know if you can see me because I brought up my screen so I could read my question properly to you. Can you guys still see me?
Yeah, we can see you.
Okay, great. You can't, can you see my screen though?
No.
Okay, good. Okay, I want to know the following. I want someone out there who paid attention to name the 3 attributes that we can assign to a voxel to get the spectacular images. There are 3 attributes.
Not such an easy question.
You know, we might even give them, you know, the first, whoever gets the first 2. How do we,
Can you
how
call a
do we
friend?
get,
Is it
sorry,
50-50?
what?
Is it call a friend 50-50?
Yeah. I'm watching the Q&A and I don't see anything coming up on there with a. Ah, I see the, someone got it.
Is it already?
Simone Morkel.
Oh,
Do you see it there? 1127. I think that was her. There's lots of people guessing. Oh, I'm sorry. And Nadia DaCosta at the same time.
both right.
So I see 2 people that answered correctly. Others got portions of it. So I don't.
Okay, well, that's fine. If we have a tiebreaker, we will do have another tiebreaker question then. Okay, so if there's 2 people with the same answer and at the same time, then do you want to, well, unless
I don't want to pose another question. One of those people is going to get mad at me.
well, then both of them win the prize. So we're going to have space for another one on the course, maybe 21. That's fine.
I'll let you guys decide. You'll have to figure it out.
2 times, they both win. So
He's
Well
such
done.
a nice guy. Woohoo!
Well done, Peter.
And good job to those people, by the way.
yeah,
Yeah.
very good, very good. Okay, I think Brian, any final words?
No, just thank you, Dale. That's fantastic as usual, and we just can't wait to get you here. So you speed up and get here already.
All right, well, open a pinotage and let it breathe. I'll be right there.
You got it.
Good evening, everybody.
Thank you very much.
Thank you very much for watching. And once again, Dale, thank you so much. And God bless you guys in America. I hope all goes well. And we look forward to seeing you in February. And have a Merry Christmas. And we look forward to a great 2021. Good.
Peter,
Thank you.
interrupt?
Yes, please.
Please do the selection of the 3 numbers for the lucky draw.
Sorry, I missed. Was
The 3 numbers that Dr. Dale needs to choose.
Oh, sorry. Yes. Sorry, Dale, was beside the question. Is it 3 numbers or 1 number? 3 numbers. So you need to choose
3 numbers between 1 and 410.
Yes. Your speaker is off, Dale. You just put your microphone on. Thank you.
You couldn't hear me laughing. Between 1 and 410, right? Is that what I heard?
Yeah, that's because there's still 410 participants watching. We were one stage we're 515, but there's 410 left, so we're 408
right.
now.
Well, thank you all for staying, and we're going to go with number 8, number 212, and number 319.
Thank you.
Thank you, Dr. Miles. Perhaps, Peter, would you mind to announce the 3 sponsorships again, so that people just know that, and then we can conclude.
The sponsorships from yesterday. Let me just.
No, that's for tonight.
Tonight, let me just get that one. Sorry, Melissa, just to get that back on my screen. I mentioned the ones from last night. So tonight's one.
If you don't mind, I will quickly mention them. It's a Henry Schein Dental Warehouse voucher worth 2,000 Rand and the J&J Listerine hamper. So that's the prizes from Henry Schein Dental Warehouse and J&J.
Thank you. Good. Anything else, Marlies?
No, that's good. And we say good night and goodbye.
And good afternoon to you, Dale. Cheers.
Okay, thank you guys. I'll send some info about the flights shortly.
Okay. Thank you.
Okay. Bye guys.
Yes.
Bye Brian. Good job.
Bye-bye. All right, bye-bye. Thank
Bye.
you.
Okay. Bye Lindy.
Night.
Bye Marilee.